Welcome to this video on sports injuries from an orthopedic perspective. My name is Dr. Ahmad Fahmy, and today we're going to explore sports injuries from an orthopedic perspective. Whether you're a clinician, coach, or athlete, understanding how injuries happen and how to manage them is essential for keeping people active and performing at their best. Over the next session, we'll move from basic definitions all the way through to return-to-play decisions and prevention strategies. Let's begin. Here's our roadmap for today. By the end of this session, you'll be able to do 6 things. First, define and classify sports injuries by onset, mechanism, and tissue type. Second, identify risk factors, both intrinsic, like age and previous injury, and extrinsic, like equipment and training errors. Third, recognize common injuries by region, from the head down to the foot. Fourth, diagnose and manage these injuries using assessment, imaging, and treatment principles. Fifth, stage rehabilitation and judge when an athlete is truly ready to return to play. And finally, sixth, apply evidence-based strategies to prevent injuries before they happen. Let's dive into the foundations. So, what exactly is a sports injury? Simply put, it's tissue damage that occurs during athletic activity, training, or exercise. This can affect muscles, bones, ligaments, tendons, joints, and sometimes nerves. Importantly, sports injuries don't discriminate. They happen to elite athletes and weekend warriors alike. We classify them in 2 main ways. Acute injuries strike suddenly, like a sprained ankle or a fracture. Chronic injuries build silently over weeks. Think stress fractures, tendinopathy, or shin splints. Severity ranges from minor bruises and mild sprains all the way to complete ligament ruptures and complex fractures. Why does this matter? Because recognizing the type and severity early shapes every downstream decision. What imaging to order, whether to treat conservatively or surgically, and when the athlete can safely return. Get this first step right and you're on the right track. Let's look at the scale of this problem. Worldwide, there are over 300 million sports injuries every single year. The most affected age group is between 15 and 30 years old. The lower limb is the most prevalent injury site by a wide margin, and we're seeing increasing incidence in both youth sports and active older adults. The most commonly affected sports include football, basketball, running, martial arts, and gymnastics. So whether you're working with a teenage footballer or a masters runner, you will encounter these injuries. This isn't a niche problem. It's a global public health issue that affects participation, performance, and long-term joint health. We classify sports injuries using 3 complementary lenses, and most injuries are described by all 3 at once. First, by onset. Acute means sudden, like a fracture or dislocation. Chronic means gradual, like tendinopathy or shin splints. Second, by mechanism. Traumatic injuries come from direct impact, collision, or a fall. Overuse injuries come from repetitive stress without enough recovery time. Third, by tissue type. Soft tissue injuries affect muscles, tendons, and ligaments, strains and sprains. Hard tissue injuries affect bone and cartilage, fractures and dislocations. Using all 3 lenses gives you a complete picture. For example, an ACL tear is acute, traumatic, and involves soft tissue. A stress fracture is chronic, overuse, and hard tissue. Clear classification drives clear management. Injuries happen when forces exceed tissue tolerance. There are 4 main types of mechanical forces at play. First, tension, a pulling force that causes ligament sprains and muscle tears. Second, compression, a crushing force that leads to bone fractures and cartilage damage. Third, shear, a sliding force across surfaces, like what happens in meniscus injuries. And fourth, torsion, a twisting force that causes spiral fractures and ACL tears. Here's the clinical takeaway. Poor biomechanics lead to malalignment, which leads to excessive joint loading, which creates microtrauma and eventually injury. So when you see an athlete with recurrent problems, don't just treat the injury. Look at how they move. Fixing biomechanics often fixes the problem. Now let's talk about why some athletes get hurt and others don't, starting with intrinsic or athlete-related factors. Age matters. Growing bones in youth have vulnerable growth plates. Older adults have degenerative changes. Gender matters too. Females have 2 to 8 times higher ACL injury risk due to anatomical and hormonal differences. Anatomical alignment, things like flat feet, scoliosis, or leg length discrepancy, can predispose to injury. Joint laxity or hypermobility increases instability. Muscle weakness or imbalance, especially asymmetric strength between agonist and antagonist muscles, is a major factor. But the single strongest predictor? Previous injury. That's the biggest red flag. And finally, fatigue and poor conditioning. When athletes are tired, their protective reflexes are slower. That's when injuries happen. Now for extrinsic factors, the environment and equipment. Poorly fitted equipment that fails to protect joints and soft tissue is a common problem. Inappropriate footwear, wrong sole type, poor arch support, or worn-out cushioning contributes significantly. Playing surface matters. Wet, uneven, or artificial turf increases slip and impact risk. Training errors are probably the most common preventable cause. The classic mistake? Too much, too soon. Rapid increases in volume or intensity without adequate adaptation. Weather conditions like heat, humidity, or slippery rain increase risk. And finally, lack of supervision. Poor coaching or absence of qualified medical staff means small problems become big ones. The takeaway? Many extrinsic factors are modifiable. Change the environment, change the outcome. This slide summarizes the balance between intrinsic and extrinsic factors. On the intrinsic side, we have age, sex, alignment, joint laxity, muscle imbalance, and most importantly, previous injury. That's the strongest single predictor of re-injury. On the extrinsic side, we have equipment, footwear, playing surface, training errors, weather, and supervision, especially inadequate warm-up. Here's the clinical pearl. You can't change an athlete's age or their previous injury history, but you can absolutely modify training loads, improve footwear, correct biomechanics, and ensure proper warm-up. Prevention isn't about eliminating all risk, it's about controlling what you can control. Let's look at the 5 most common mechanisms of injury. First, direct trauma, collision with players, objects, or the ground. Second, twisting or pivoting, sudden change of direction. This is the classic ACL injury mechanism. Third, overstretching, abrupt lengthening of a muscle or tendon beyond its limit, like a hamstring strain. Fourth, repetitive motion, long-term cumulative stress from activities like running, swimming, or throwing. And fifth, awkward landing, falling from height or landing with poor biomechanics. Understanding the mechanism is the single most useful clue in your history. If you know how it happened, you'll often know what's injured before you even examine the patient. Now we'll tour the body from head to toe. This slide gives you the roadmap for the next several slides. We'll cover the head and cervical spine, shoulder and elbow, wrist and hand, the thoracolumbar spine, hip and groin, the knee, which we'll spend extra time on because it's the most commonly injured joint, and finally, the ankle and foot. For each region, we'll look at the most common injuries, clinical features, and which sports put athletes most at risk. Let's start at the top. Head and neck injuries are relatively less common than lower limb injuries, but they're the most dangerous. Head injuries include concussion, transient brain dysfunction after trauma, skull fracture, and intracranial bleeding. Red flag signs include headache, dizziness, confusion, nausea, loss of consciousness, and memory loss, either retrograde or anterograde amnesia. Any evolving neurological picture needs immediate escalation. Neck injuries include whiplash, stingers or burners, which are transient brachial plexus injuries, and the big concern, spinal cord injury. If you suspect a cord injury, immobilize the neck immediately and assume it's unstable until proven otherwise. High-risk sports include boxing, football, rugby, hockey, wrestling, and diving. When in doubt, sit them out and get imaging. Moving down to the shoulder and elbow. In the shoulder, the most common injuries are anterior dislocation from a fall or contact, rotator cuff tears, the supraspinatus is most frequently involved, and impingement syndrome, which causes pain on overhead activity. In the elbow, we see tennis elbow, lateral epicondylitis, golfer's elbow, medial epicondylitis, and UCL injuries in overhead throwing athletes like baseball pitchers. Key clinical features include pain on overhead use, weakness, reduced range of motion, and reduced grip strength. High-risk sports include swimming, tennis, baseball, volleyball, golf, and weightlifting. If an overhead athlete complains of pain, don't ignore it. These injuries get worse with continued play. Now, the wrist, hand, and spine. In the wrist and hand, we see scaphoid fractures from a Fuchs injury, that's fall on an outstretched hand. Watch for anatomical snuff box tenderness. Even if the x-ray is normal early on, you still need to suspect it. Also, jersey finger, a flexor tendon avulsion, and mallet finger from extensor tendon rupture. For the thoracolumbar spine, common injuries include muscle strains of the erector spinae or multifidus, spondylolysis, which is very common in gymnasts, and disc injuries with radiating leg pain. What to watch for? Any loss of finger flexion or extension suggests tendon avulsion, and any young athlete with low back pain and stiffness should be screened for spondylolysis. Don't dismiss it as just a muscle strain. High-risk sports include basketball, cricket, martial arts, gymnastics, and weightlifting. Groin and hip pain can be tricky because so many structures overlap. Common injuries include hip labral tears, which cause a catching pain deep in the joint, adductor strain, which is the classic groin pull, and snapping hip syndrome, where the patient feels or hears a snap with movement. Clinical features include pain on flexion or rotation, clicking or catching, suggesting intra-articular pathology, and local tenderness over the adductors. Here's a clinical pearl. Groin pain is a crossroads. The hip, adductors, hernia, and pelvis all overlap. You have to examine the whole kinetic chain. Core and pelvic control matter enormously. And adductor strains are notoriously slow to settle and frequently recur. High-risk sports include soccer, martial arts, ice hockey, and sprinting. Now we come to the knee, the most commonly injured joint in sports. First, ACL tear. This happens with sudden pivot or deceleration, often non-contact. Patients often hear a pop, develop rapid swelling, and complain of the knee giving way. Second, meniscus injury. This happens from twisting with compression. Patients have joint line pain, locking or catching, and delayed swelling, usually the next day rather than immediately. Third, patellofemoral pain. This is overuse or maltracking. Patients feel anterior knee pain worse on stairs and prolonged sitting. Cardinal symptoms to ask about: instability or giving way, swelling, locking or clicking, and loss of full extension. And the most sensitive bedside test for ACL integrity? The Lockman test. Always do it and compare to the other side. High-risk sports include football, basketball, skiing, and netball. Finally, the ankle and foot, where the most common sports injury of all happens. In the ankle, we see lateral ankle sprains. The ATFL is the most commonly injured ligament. Also, high ankle sprains, syndesmotic injuries that are slower to heal, and Achilles rupture, which patients describe as a sudden kick in the heel. In the foot, we see plantar fasciitis, overuse heel pain worst with first steps in the morning, metatarsal stress fractures, insidious load-related pain, and turf toe, hyperextension of the big toe. Signs to look for: pain, swelling, inability to weight bear. Use the Ottawa ankle rules to decide if x-ray is needed. Poor footwear is a modifiable contributor, and hard playing surfaces raise stress fracture risk. High-risk sports include trail running, badminton, football, basketball, and dance. Our focus shifts to diagnosis and management, encompassing initial assessment, appropriate imaging, conservative care, and surgical options. A structured history and physical examination will solve most cases before you ever order a scan, but you need to do it systematically. Let's start with history. You need to know the mechanism of injury, direction and energy of the force. That's the single most useful clue. Onset and timing of pain, immediate versus gradual, and the swelling timeline. Functional limitation. Could they continue, weight bear, compete? And previous injury, plus red flags like neurological symptoms. Then physical examination. Look for swelling, bruising, deformity. Feel for point tenderness, warmth, effusion. Move through active, then passive range of motion, comparing sides. And then do your special tests, targeted tests like the Lockman for ACL or O'Brien's for labrum. Do this well, and you'll be right most of the time. Imaging confirms what you suspect from history and exam. It doesn't replace it. X-ray is fast, cheap, and widely available. Use it for fractures, dislocations, and alignment, but it misses soft tissue injury completely. MRI is the gold standard for ligaments, tendons, cartilage, and bone marrow. Think ACL, meniscus, labrum, but it's expensive and time-consuming. Ultrasound is great for dynamic assessment of tendons and muscles. It's real-time, portable, and good for guided injections, but it's operator-dependent. CT scan gives excellent bony detail for complex fractures and joint surfaces, but has higher radiation dose. And bone scan is sensitive for early stress fractures and infection, but has low specificity. Choose the right modality for the right question. Don't just order an MRI for everything. Most sports injuries don't need surgery. Conservative management is the backbone. Everyone knows RICE. Rest, but relative rest, not complete immobilization. ICE, 15 to 20 minutes every few hours. Compression, elastic bandage to limit swelling. Elevation, above heart level to promote fluid drainage. Beyond RICE, we have NSAIDs for pain and inflammation control, ibuprofen or naproxen, physiotherapy, exercise rehab, ultrasound, TENS, manual therapy, immobilization with splints, braces, or casts when appropriate, and corticosteroid injections for persistent inflammation, but use them judiciously because repeated injections can weaken tissue. The key is to protect the injury while maintaining as much function as possible. Complete rest for too long leads to deconditioning. Find the balance. When conservative management fails, or the injury is severe, surgery is indicated. Common surgical scenarios include ACL reconstruction for high-grade tears in active individuals, meniscus repair or meniscectomy, the approach depends on the tear pattern and vascular zone, rotator cuff repair for full-thickness or functionally limiting tears, and fracture fixation, ORIF, for displaced or unstable fractures. Advances in surgery have been significant. Arthroscopy allows minimally invasive procedures with less pain and faster recovery. Grafting and reconstruction using tendon grafts restore stability. Post-surgical care involves pain control, protected immobilization initially, and then staged progressive rehabilitation. Surgery alone doesn't fix the problem. Rehabilitation after surgery is what gets the athlete back. We now transition to the final section, focusing on rehabilitation, the criteria for returning to sport, and effective prevention strategies. Rehabilitation happens in 3 phases. Phase 1, the acute phase, days 0 to 3. Goals are pain control, inflammation reduction, and protecting the injury. We use RICE, NSAIDs, gentle range of motion if safe, and immobilization if required. Phase 2, the subacute phase, day 3 to 3 weeks. Goals are regaining range of motion and beginning strengthening. We introduce progressive stretching, isometric and isotonic exercises, joint mobilization, and proprioceptive training. Phase 3, the remodeling phase, 3 to 6+ weeks. Goals are restoring strength, proprioception, and sport-specific function. We use resistance and functional training, sport-specific drills, plyometric loading, and neuromuscular conditioning. Progress through these phases based on clinical response, not the calendar. Return to play is a decision, not a date. Athletes earn clearance against objective targets. First, they must be pain-free with full range of motion. Second, strength must be greater than 90% compared to the uninjured side. Third, functional tests must be passed. Hop tests, agility drills, sport-specific movements. Fourth, no swelling or instability under load. And fifth, psychological readiness. The athlete must have confidence and trust to compete fully. Then use a graded return. Controlled drills first, then modified training, then full training, then full participation. Progress only when each stage is symptom-free. Returning too early is the single biggest predictor of re-injury. Be conservative, especially with young athletes. Let's end where we should always start: prevention. The evidence is clear. A proper warm-up and cool-down prepares tissues for work and restores them after. Strength and flexibility must be balanced across each joint. Proper gear and footwear, well-fitted, sport-appropriate, reduces risk. Neuromuscular control training, balance and proprioception is highly effective, especially for ACL prevention. Hydration and nutrition optimize tissue resilience. Rest and sleep allow recovery. Overload without recovery is a recipe for injury. Athlete education about body mechanics and early symptom reporting empowers them to speak up before a niggle becomes a rupture. And load management. Progressing training volume gradually prevents the too much too soon injury. Prevention isn't glamorous, but it works, and it keeps athletes in the game. Let's summarize what we've learned today. First, classify every injury by onset, mechanism, and tissue type. That simple step drives every decision that follows. Second, assessment and diagnosis are key. A structured history and look-feel-move exam with imaging matched to the tissue solves most cases without over-investigating. Third, individualize rehabilitation and return to play. Stage the rehab and earn return against objective criteria, never the calendar alone. Fourth, prevention truly beats cure. Integrate conditioning, neuromuscular control, load management, and athlete education. And finally, understanding sports injuries isn't just about treating problems. It enables safe peak performance. It lets us protect athletes and restore them to what they love doing. Thank you. Thank you for watching this video.